A very good morning to one and all present here. On behalf of OPTOBHARAT, I warmly welcome you all on today's webinar on Retina, a clinical approach. I am Shia Sinath and I have the privilege of moderating this session. A quick word for OPTOBHARAT. It is India's largest optometry student community, created to unite and empower future eye care professionals through learning, collaboration, and knowledge sharing. It is my honor to introduce our guest speaker, Mr. Sanjay Mehta sir, an alumnus of the elite School of Optometry with over 35 years of clinical experience. He is the founder of Tower Optics Chennai and is widely respected for his expertise in retina and glaucoma, with multiple national awards to his credits. With this, I now invite Mr. Sanjay Mehta sir to begin his presentation on retina. Sir, please begin.
Yeah, thank you very much. And congratulations for you have now some around 1,000 followers in LinkedIn. All the best for for much more followers. Okay, so we'll start now. Thank you very much for inviting me. I'll share my screen now.
Yes, sir.
1 minute. Um, as the topic you are aware, the retina, all of us know what this is my clinic. Okay, this is my clinic. So this is where I practice. I've been practicing for so many 35 years. Of course, it has modified over the period of time. Okay, now coming to the anatomy, we'll start with anatomy. Basically, all the anterior structures and the posterior structures you're well aware, but I feel one thing that basically all this whatever we see here, the primary aim is only to focus the light on this small tiny place called fovea. And this fovea, this retina is made up of all the structures. These are the main structures which I feel which makes us see properly. Um, and as you must be aware that there are about 10 layers. I would like you to see the left side part of the screen, wherein these are the three main areas of the where the whole drama happens. Okay, the one in the on the top is nerve fiber layer, ganglion cells, and that is very important to that is to check the that's where the glaucomatous changes happens. This middle layer is where it keeps the whole retina intact, and the rods and cones, and then the photoreceptors, pigment epithelium, Brooks membrane. These are these are the parts when this AMD or retinitis pigmentosa and all that happens here only. Now, one more important part I would like you to see is this part called lamina cribrosa. So it is made up of like a small pipe it is, and with small holes. You can see a sort of a mesh it is. Generally, we'll see near our in our when you will see many of the places this small hole, a small what do you call it as a tin sheet is there. It'll have tiny holes. So it is almost like that only. It allows all the nerve fiber layers and the um, our retinal vasculature to pass through this. This is very important part. Whenever I do any observation, you will come to know. I'll show you again afterwards. And after passing through the eye, the any image through the optic nerve and the optic tract goes to the cortex. All this happens in a matter of 100 to 150 milliseconds. The whole processing from when right now what you're seeing and analyzing and you are interpreting whatever you are seeing this image happens in matter of 150 milliseconds, 100 to 150 milliseconds. Now, basically, what the retina we check by we can assess it functionally in simple ways by visual acuity. We do it with the help of retinoscope and AR, and there are other functions of other tests like pupillary light reflex, Amsler grid, color vision. All these are reflecting on how the macula is functioning. One more test is visual field test, wherein uh, we can assess how much the damage is happened to the optic nerve as well as the other part of the retina. You can see there is on the left side there is a gold standard Humphrey, and nowadays on the right on the top you can see the portable visual field analyzer, which I also have it. We have also visual evoke potential and visual evoke response that tells the integrity of the whole path of the optic nerve from the retina till the brain. And we have to now to see it physically, we have direct ophthalmoscope, wherein we can have a very good picture of the retina. But still I feel somehow though the image is magnified, it loses its, I mean, it's unless the pupil is dilated, I'm not very comfortable using this. Okay. Then we have indirect ophthalmoscope. This is the gold standard of examining the retina. It takes a lot of effort and understanding of the whole optics of the how the image is inverted, and you have to see whether it is right and left, up and down, all that. But it is one of the gold standard. So once you master this one, it is nothing like that. Then we have 90D lens, wherein through using a slit lamp, making a slit, with the help of the slit, we can see the optic nerve easily. Again, sorry to say, I'm not very expert in this. I have not tried it, though it was there in my practice. Then we have the applanation tonometer, which is the again the gold standard for measuring the IOP. That is also important in the to check the health of the optic nerve. Then we have fundus fluorescein angiography, wherein fluorescein is injected into our through the wrist vein, and the and series of pictures are taken to see the flow of the dye in the eye, retinal vasculature. Yeah, and at the same time that will give an where the blocks are there. Nowadays, with the new, I'll come to that again. So in my practice, in the last almost 7 years, probably the first I used was this fundus camera. The reason why I felt was, even if I was seeing anything, I was not able to document it. So in the left side, you can see the fundus handheld fundus camera. I got it almost 15 years back. And on the left side, you see that was the first image taken from that. It's very dear to me, that one, because this is the first picture. Then have non-meteoritic fundus camera, and then we have the NCT with pachymeter, it is there. So what you see on the bottom is the picture taken by all these machines. Its relevance you will come to know later. I'll show you. Then we have OCT. It has a there is, you can see a small spectrometer is there, and with the help of that, the deeper layers of all the or not only the macula is seen, all the layers, but we can see the optic nerve head, and the report which is given. Many of you must be aware also, is on the uh, bottom on the left side of it. So it has its own use. Now, this is the have seen so many retina pages images. I have a collection of around 8,000 images, but this is the only picture which is like a book picture in the what you see in the books. This is the only one. It was on a World Sight Day, and this is a perfect retina. What is described in the book? There is nothing like perfect retina. There are so many variants of a normal retina. So that's why the diagnosis of retina becomes little bit tricky. Anyway, so as you can see here, there is a this is the optic disc. This darker red color you can see. This is the vein, and the thinner one is arteries, and this is the main center point wherein which is called macula, which is around about. Hello, hello. I'm audible. Hello, hello. Can you unmute that person? Hello,
Sir, you are audible, sir.
audible.
Yes, sir. Yes, sir.
Hello. Yeah. Okay. Now comes to the dimension of the optic disc. Sorry, the retina. You can see the optic disc is there, and then the fovea is approximately 2 disc diameter away from from the optic disc. That helps in in estimating the whether the optic disc is swollen also or not. Or is there anything between the fovea and optic disc also? We can measure it that way. For documentation is helpful. Now there is one more thing very important you should see here, as I'm pointing it out. That is the optic cup, and this zone between the rim here and sorry, between your optic disc margin as well as, and this is called neuroretinal rim. Generally it is yellowish pinkish in color, and it is should be uniform. This part will be slightly lighter than that. And of course, there is one here, something is mentioned. This is a mention here is cilioretinal vessel, and that helps the preservation. That is the artery which supplies blood to the macula, though it is a avascular zone, but that's where it is nourished, uh, and that is has its own clinical relevance. So even in advanced stage of eye disease, macular disease, vision is still maintained because of the help of this vessel. Now, this is very important. This is called ISNT rule. So it basically means the rim thickness is more at the inferior zone, then at the superior zone, then at the nasal and the temporal. So the thinnest one is at the temporal zone. So in case of any changes happening, though it is mentioned here of glaucoma, wherein it is, so this will get disturbed. So if you see what this has grown vertically, so even in glaucoma cases, more than nasal temporal increase, it is the inferior and superior changes is very important. The reason being that the nerve fiber layer, okay, which are uh, moving like this from the optic disc, or I would say it's going from there to the from to the towards the optic disc, vice versa we can call it. It goes in an arcuate uh, format. So now what happens here is this both goes, um, this being maximum nerve fibers are passing this way. So this way this becomes crucial even in as far as the vision is concerned also. Nasal radiation is not that basically important because it occupies very little portion of the of our view. Now, so now physically, how does retinal fiber layer look like? So if you see here, the where I have made this arrow, this is a lighter zone of the retina. So what you can see is a nerve fiber layers are nicely radiating from here. Um, it's very difficult to see more than this, but many in healthy patients we can see up to here also. But you can see this white zone which is there, which I have marked. Why it is important is you will come to know. Always remember to see this part. very carefully, as well as the optic disc. Of course, macula is there. Now, my journey towards retina started with this thing. When I started my practice, very early in my practice, probably within a year or two of my practice, I had in my clinic I had only a slit lamp. Probably that time, yeah, only a slit lamp was there, and direct ophthalmoscope and indirect, the direct ophthalmoscope and retinoscope was there. Nothing. So I remember that day very clearly. A young boy, must be of age 18 or 19, came to my practice saying that my vision is not clear. He has been to, sorry to say, he had been to an ophthalmologist who has prescribed him glasses, and he said still that I was not clear. So when I examined his eyes, everything vision was not. We are not. I was not able to correct it more than 6:9 and 6:12 in another eye. And then when I had a look at his optic nerve, it was chalky white, absolutely pale. Then I was not equipped with any of the instruments in my clinic or any other. So I color vision chart also. So I use the uh, cycloplegic and other drops caps, and did confrontation test. So I forgot to mention there, but for checking the visual field, also confrontation test is very crucial. We can do it when you don't have any other uh, equipment. So coming to this case, so I did the confrontation test, and then it was reduced. The color vision was also was very. I used the same bottle caps to check the color vision, so it was totally washed out. So I said definitely, and there was RAPD, relative afferent pupillary defect. I said something is definitely wrong beyond the eye. It is nothing to do with the eye. So I told him, "What is your father doing?" I asked him, "What is your father?" He says he is working in a hospital, very big hospital in Chennai. I said, go immediately. I feel there is something wrong behind, and it is something dangerous. He did go, and they found that he had a pea size life threatening tumor at this chiasma, which is the and which was causing that optic disc changes, which showed optic disc changes, as well as the vision was lost. And the tumor was just pea size, and it was so in a very dangerous condition that I came to know later about it, that the it was life threatening one. Had they come, that boy would have gone a week later. Uh, he would have lost his life. So much. This was very crucial. This was really eye opening for me, and so from chashma to chiasma, it is. This case was. So as you see this, very commonly we come across this nowadays. Myopia is in everyone is talking about myopia. So what this high myopia can cause? Absolutely, the retina is thinned out totally, and you can see here totally. We can see the whole choroidal vasculature behind totally. The arteries and veins are also thinned out, and here it is stretched so much that you can see the behind sclera also clearly. So, so as everyone I think must be aware, but I'll still say this is the diabetic retinopathy. Nowadays, many more and more people are getting diabetic. So one, all of you should be seeing this case more than any other case. But physically, in my practice, the difference is I see the cases when it is just would have just started, because in the book picture we see is very different from what we see actually in the initial stages. So this, I had a patient, you can see his eyes are flooded with these dots, diabetic changes are they are evident. She's, and you can see a small hemorrhage also here at the bottom of this place. For examining the retina, one very important thing: don't miss out on the smallest features. So here also, if you can see, the arteries are thinned out. There are some flood hemorrhages here also. Now, what does uh, this look like? If anyone want to talk about it, they can unmute for a second. and let me know what does this picture look like. Observe carefully. Anyone? So this lady came to my clinic. Just she was around 43 years old. She came, said, I just wanted, not able to see clearly near objects. So generally, if any other clinic would have been there or any other place, they would have prescribed. She was using, her distant vision was 6.6, and with plus 1.25 addition, her rear vision is all right. But this picture really took me aback. I said something is definitely wrong here. There is a total loss of this retinal nerve fiber layer, which I told you in the early picture. Absolutely, there is nothing there, and you can see this. This is called alpha and beta zone. So in a 40 to 43 years old person, unless there is a myopia, you won't see this. So I said something is definitely wrong. So when I checked her eye pressure, it was around 34 in one eye and 24 in an eye. So this is what I was talking about. And when I did my visual field test on same patient, you can see this. This is total visual field loss is there. Uh, by the time I had referred her to an ophthalmologist. By the time the treatment started, pressure was somewhere around 60 in one eye, another eye 70 it was. Of course, she is better now, but definitely these are all the changes. This type of cases we'll see. Though what this case shows that though our 6.6 and 6 is not normal, is not enough for an optometrist. Now, this is how the changes will take place over a period of time. This you can see, this is almost a normal pupil, normal optic disc. Then this cup disc ratio increases, and here you can see what we called it is as a bayoneting of the vessels. They kink inside down, and there are so many other features of a glaucomatous cupping. This can be even a normal cupping. Okay, it depends. Glaucoma is such a condition wherein we have to take into account all the factors: visual acuity, the eye pressure, optic nerve changes, corneal center thickness, at the same and of course visual field test, and how the of course the angle of the anterior chamber angle also. Now this is what I was talking here. Sorry, this is what it progresses. This is, and we always measure it by uh, zero point 0.3, the size of the cup relative to the size of the optic disc. So here both are almost merging. This is a perfect example of a glaucomatous cup. I'll show you also. So this, I had a patient here again, is coming for the same problem. He was around 42 or something, and he said, I'm not able to see, I mean, just near vision. So here you can see such a big optic nerve has been damaged and is asymptomatic, absolutely no symptoms at all. And here little bit of nerve fiber layer is present, but here on the top is totally gone. So this patient has referred, and again uh, he is under watch. Okay. uh, because his angle is very open. So absolutely, they have not done anything to. There is on drops right now. Now this one more patient came. She must be in her mid 50s, and if you see her macula is very just like any young person macula it will be. You can see the yellow reflex also. But what struck me was such a pale optic disc it is there. So when I asked her history, I said, "What is it?" She said that she had heart issues and she was taking some medicines for that. So these medicines also can cause problem in the optic nerve, and as in this case, it has become chalky white. And you can see this. I have taken the OCT of that. It shows clearly shows that there is a defect in the optic nerve. Also, I have taken the ganglion cell thickness. This is what I always want to like to see. And here you can see this portion of it is totally damaged. It is thinned out. Though this center zone is intact, but still there is a lot of loss is happening. So this patient has also has to change the medicines, and we have to keep in under watch. absolutely, and her vision was 6, 6, and 6. Now, this is also a lady came to my place, just says my vision is blurred. In turn, it turned out to be branch retinal vein occlusion. Okay, and mostly it is on the top, on the superior portion, but it in their case it is on the bottom. And along with that, you can see this. These are sorry. So these are she is diabetic, hypertensive, everything is there. So you can see this portion of it is there are a lot of diabetic retinopathy changes are there, and her arteries are somewhat. I mean, see these veins are a little bit engorged. So when one thing you should always see is the. I'll show you one more picture wherein you will come to know the artery and vein ratio. Generally, it is two is to three. In conditions, I will come. I'll tell you about it. In that, it will reduce. So another common thing we'll see is nowadays is this drosens. Any anyone around 40, 50, you will see this in small numbers. It's quite common. The significance of this one is that it can, if the patient nutrition is not maintained properly, it can turn out to be an AMD later. This is a massive one here. You can see this is called wet AMD, wherein the blood leaks out from the retina and then it coalesces and then they form it over here. This patient vision is very, very poor. And these are all real patients. Real images are there taken in my clinic. So then one more thing I had come across is this called epiretinal membrane. So many of the conditions like diabetes, any inflammation, what happens, the retinal cells gets damaged and they coalesce and they form this membrane. The significance of this one is this membrane, it can lead on to retinal detachment also. So this has to be generally nobody touches it. It's so but but it can be removed, especially since this is at the almost at the macula, so it have to be carefully removed. But it can lead on to retinal detachment. So as I told you, so this gentleman came with a complaint that suddenly he was sitting in a in his chair and suddenly a curtain had fallen on front of his eyes. So this is what it was at the periphery, and of course it was taken care. So this small simple complaints, but it can be a different thing altogether. So one common thing also we see is medullated nerve fibers. The after, approximately 2 to 3 months after birth, the nerve fiber layers they disappear. But what happens is many of the times they remain on the retina like this. So this can lead on to amblyopia in most of the cases. But sometimes this is in this case it is amblyopia is there. I have seen in when it is small, when it is in less number, it covers less of the area. It is the patient vision is maintained. Now, this is what retinitis pigmentosa looks like in an advanced stage. Everything is there in this case. You can see this bone spicle formation, optic atrophy is there. So you can see these arteries are thinned out totally. Absolutely, this person does not have any vision. You can see this is the macula, wherein it is totally damaged. So, and this is also one of the genetic condition called Stargardt disease, in which the this macula is affected and gradually the vision loss happens. See what happens here is in what we see in the book picture, it will be slightly different from what actually really is, because there are so infinite possibilities are there as far as human beings is concerned. The same applies to the condition appearance also. So now this is called toxic retinopathy, wherein this gentleman who's been working in railways and he was handling batteries for the last almost 25 years. Over a period of time, because of this exposure to those toxic fumes over there, and the battery, which is, of course, it has so many other harmful things. He has developed this toxic retinopathy. This totally, the macula is damaged. Absolutely, vision is very, very poor here. One more thing, striking feature you can see is this prominent vein here. So whenever there is a prominent vein, that then what does it mean? Actually, it means that there is a disturbance in the retinal vasculature flow, everything. Now, I had a patient who just ran in my clinic saying that 15 minutes back, I'm suddenly seeing one black dot in front of my eye. So it turned out to be a central serous retinopathy. uh, he was seeing a scotoma here in front of his left eye. And sorry, one more thing I forgot to tell, how to identify. There's always a confusion, uh, which is the right and which is the left eye. Left optic nerve, retina pix is concerned. So this optic nerve, as you can see here, is on the left side of the picture. So that is the left retina, and the macula is on the right. Okay. So 1 minute, second. Sorry. So this is very easy way to identify the picture, whether it is for the right eye or left eye. So this gentleman had central serous retinopathy. Sorry, I forgot to add one more picture in this center. I had a case wherein generally it is unilateral, but I had a case wherein it was there in both the eyes, massive one. So when the through the OCT, the CSR looks like this. It took about probably almost 2 months of his taking rest. So history taking is very important. I said, what happened in this? What made it happen? He said, sir, I have for last 15 days I have been traveling hectically. Some and many of the nights I have not slept also. So and he's a very anxious person. We can very he doesn't stay in one place also like that. He's a type A personality person. And over a period of time, he said, no, I want to take care of my eyes. It took break from everything, and probably within 2 months, it became quite normal here. Became normal, and it is maintained. In between, one time it again became bad, but then now for last almost 1 year, it is stable. Now, one more thing we have come across is this called pseudomacular hole, which is, though it looks like a macular hole, but it is not. So how do we make out? His vision will be always be 6 by 6. No, I mean, or it will be within normal limits. But in the OCT which I took, I was able to see this. If it would have been a full thickness hole, it would have covered fully here. Okay. So this is a pseudo hole. The patient has to be advised that not to um, pull heavy, carry heavy objects or pull anything from the ground heavy suddenly and all that. One more common thing we come across, this is called posterior vitreous detachment, whereas the vitreous gets detached from the macula. Generally, it is almost covering the macula throughout, but in this case, it is totally detached. So the significance of posterior vitreous detachment is there is no real treatment for that. It can lead on to, it can cause retinal detachment also. Vision loss is definitely going to happen over a period of time, but if not, if it is good deteriorated. So now this is a very interesting case. I had it in during the just after the during the first lockdown. A patient came running. He said, "My vision is blurred." So of course his vision was less, 6.9, 6.12 it was. What's striking was this retina. Here you can see this. This is there is a blood hemorrhage on it. There is also blood hemorrhage here, and it is over here. And the disc margin is also not very clear. So he had, I said, just check your blood pressure. So he had a sudden increase in blood pressure, and this has caused this. So there is one more small blood hemorrhage here. So you have to observe all these things, small things are there, which will lead on to diagnosis of the condition. So this generally in the book picture, or it will be written like this. Later it can develop like this. This is also one more patient of mine. is an advanced case wherein you can see those flame shaped hemorrhages are there. And in generally, these are the features of any hypertensive retinopathy like that. Now, this is one more very interesting case of mine, wherein a patient, to a customer of mine, to whom I have given what do you say, spectacles. Just say 3 months old, he says, I'm not able to see properly with the glasses. I said, within 3 months, it wouldn't change. So, with his permission, I said, let me check your eyes. He said, yes. What I found is it is called, and the veins are dilated here. The arteries are absolutely thinned out. Okay. And you can see this small yellow spots here I'm mentioning here. So these are all the changes which are happening in his retina. So I asked him, what is your systemic condition? He says, I'm hypertensive for the last 10 years, diabetic for the last 35 years, increased cholesterol is also there, thyroidism is also there. He says that every day morning he goes for a walk, and after coming back from the walk, when he tests his blood sugar for the last almost 2 weeks, blood sugar, it is going increasing. Generally, he expected it to always to go down, but it was increasing. So I said, then what else you have? He says, I'm having a gastric pain, which is not getting subsided, uh, even if I take tablets for the last 1 week. I said, definitely something is wrong in your cardiovascular system. Definitely, these arteries are thinned out, very, very thinned out, very badly. And you can see inside also there is a lot of sclerosis is also there. And this AV nicking, wherein the arteries become so hard and they start changing the shape of the what do you say, the path of the veins. So he did go to his cardiologist. It turned out to be he had there is a 75% block in the main left descending artery, which supplies blood to the whole body. And this is called, as I, 1 minute, I'll go back. This condition is called widowmaker, wherein the heart attack is fatal, non-revivable, sudden, so dangerous condition it was. So he underwent stent, ballooning, all that was happened, and his life was saved. This is one of the most dangerous heart. It's called heart attack of all heart attacks. So you have to collaborate not only your retinal findings with the complaint as well as these systemic conditions also. This you will come across in many cases. Is called asteroid hyalosis. What makes me this case, I mean, people consider it as benign and all that. But in one of my patient, I saw the difference. So when I checked his anterior segment earlier, it was quiet, nothing was there. But when he came later, second visit, there were a lot of asteroid hyalosis was there. I said, something is definitely wrong. Just check in your body. Something is going on somewhere. Unfortunately, his pupil size was so bad, small, that I could not take his retina pics properly. But then he came again after 4 months. He said, I went and met one cardiologist friend of mine. It turned out to be that he had again, there were blocks were there. So when he came back again, I could not, almost this asteroid hyalosis has disappeared, either because of the drugs he must have been given, or it was the asteroid hyalosis was just an indicator, because anything related to cholesterol is nothing but a warning sign that they are called actually firefighters, that something is wrong in somewhere in the vasculature. So this is a very again interesting case. A friend of mine, my childhood friend, came to give me a wedding invitation of his nephew or something like that. So he said, "No, I'm not able to see properly. Just we are talking," and he said, "Okay, let me check." It turned out to be this full this left this whole view was very muddy. And I checked all the symptoms and all that. He said, no, nothing. He said, I had a tooth extraction, some so almost some 4 years back. I asked whether you have any pets and all that. I said no. He said no, nothing. He said there's definitely something is wrong. Go is what I narrowed down it to be a case of tuberculosis, and indeed it turned out to be a tuberculosis case only. So the whole this was slightly a better picture, but when he came, it was totally muddy. Absolutely, I could not see anything is there. So there was an inflammation in the uveal portion of the posterior uveal part of the retina. Now, this is a very recent case. This lady came to my clinic saying, I'm having a constant headache which is not going for the last almost 1 month or so. So when I had a look at this retina, this is a case of papilledema due to increased intracranial pressure. After a pregnancy, suddenly she had gained a lot of weight. Earlier was she was very slim and all that, but she has gained a lot of weight. So there is something has happened. Her pregnancy was also not, her delivery of the baby was also not very normal. Though it was sorry, normal, but it was not. It was a lot of events happened with that. So when I sent her to a neuro ophthalmologist, so I had sent to him also this old picture of. So she this was taken about almost 3 years back, wherein there is no papilledema, everything is normal. Here you can see total disturbance has happened. So the neuro-ophthalmologist said well, thanks a lot, because this old picture helped him in diagnosing the case much easily. Because earlier I had sent only this picture. So then we were talking, and then I told him I have a old picture also. So even here you can see her vision is very normal. 6/6 vision is there. Macular reflexes, everything is there clearly. And there is one more condition called neuroretinitis, wherein it gives like a star radiating pattern. Um, okay, now I have an NCT pachymeter in my clinic. So one day I was thinking that this pachymeter is absolutely of no use. Really, I was thinking like that. I've got it and it's absolutely not giving. Bang! Just within a week, it gave me a picture like this. Okay. So the normal corneal center thickness is around 550, okay, a micrometer. But in her case, it was 638, 640, the right and left. So when I had a look at her retina, you can see this. These are the blurred margins are there, and the arteries are also not very. There is a light engorgement or engorgement of the thick. So I would call it a thick veins are there, but I said something is definitely wrong. So I asked her, "Are you having any other?" She is just hardly 24 years old. She was obese, 130 kgs, and she said, "I'm having thyroidism." I said, "Are you taking it properly or not? Your medication?" He says, "No, absolutely. I have stopped taking also." So I said, "Definitely go and check." She did went and check, and the thyroid levels were very low. So then I found that then I went and read somewhere that increased corneal center thickness is connected with hypothyroidism. So I said, okay, this is what it is giving me some diagnosis at last. So sometimes diagnosis becomes so difficult, and sometimes uh, to voice out to someone your finding, it becomes very crucial, and because a lot of opposition will be there, so many other things there. So I had a young lady came to my clinic, and when I checked her retina, I said, this is not normal. The disc margins are sorry, for a young patient, the disc margins are very abnormal here. You can see that, and there is a alpha beta zone is also there, which are the two layers. You can see this zone. So it is something is definitely wrong, and this vasculature is not normal. I asked her anything is all right or not. She said, "Yeah, I'm all right and all that." And probably a month or so after that, she called me and said, "Sir, I had a complete blackout of vision for 1 week, for 1 day, sorry, 1 day, and it was in both eyes, and followed by a massive headache." So she went to a neurologist, and they found that they diagnosed as ocular migraine. I said, okay, must be. She came just 10 days back. She called me, sir, I am in your area only. I'm having a massive blackout again. And she came to my clinic running. I said, definitely something is wrong again. Of course, the blackout recovered within when she was in my clinic. So I told her definitely something is wrong in your eye, some in your body somewhere something is going on. Again, she is a mild myope, 6/6 vision, everything is normal here. So I said then I said you better check your every parameters, body parameters. So she had a master checkup and they found that her cholesterol levels are very high and her blood pressure has also increased dramatically. So I said this definitely this is what I had seen her 3 years back. Definitely, had she would have taken it seriously, that blackout things would could have been much better. So as you can see here, this was taken 3 years back almost, and this is the latest one. So I will conclude with saying that every retina has a story to tell if you are willing to listen. So, patient history, patient complaints, uh, your findings, everything should go together for making a diagnosis. That's it, I will say. Hello?
Hello, hello. Yes, sir.
Yeah, this is, now I'm open to questions.
Sir, can you explain pseudo-macular hole once again?
Yeah, sure. See what happens here is, I'll show you the 1 minute. I'll share my screen. Yeah. So can you see my screen?
Yes, sir.
Hello? Yeah. So here you can see the macula here is a, there are full layers, 10 layers are there here. So here what happens here is the only the top 4 5 layers are getting damaged, and here you can see it is it is a not a full thickness hole. So if it is a full thickness hole, vision will go for a toss. Absolutely, vision will get affected. Here everything is maintained, vision is normal, but this part of it is gone due to some reason it has happened. Generally, it is a benign condition, but always it has to be watched throughout. Okay.
Okay, sir.
Good morning, sir. Sir, what are the conditions that cause epiretinal membrane?
Ma'am, diabetes, hypertension, any inflammation. So what happens that is, see, those the any whenever there is a what you call it as a there is an inflammation is happening, retinal vascular changes are happening in this condition, the cells gets damaged. So the cells gets damaged and there is not they nowhere. So the retina is thinner than our hairbreadth, so thin it is, so they don't have any place to for it to go, so it just remains there, and that they coalesce together and they cause that causes the epiretinal membrane.
It means we can say that if there is any vascular problem present, then it will cause epiretinal membrane.
Yes, it definitely can cause. Ma'am, what happens here is, see, those any diabetic patient or hypertensive, they are taking tablets. So it is helping them also in many things. So to take care of that condition. But how the body is reacting to our medicines, we don't know. And the retina, so our eyeball is such a small place, and there something is happening, and the inflammation and those retinal cells get damaged and they form this type of thing.
Okay, sir. Thank you.
Yeah.
Sir, can you explain the difference between physiological cupping and glaucomatous cupping, sir?
Ma'am, okay, now what happens here is a nice question. In glaucomatous cupping, generally it is unilateral. The one eye has a bigger cup disc ratio change is there. In physiological cupping, generally both eyes will have the same cupping will be there. So glaucoma to call something as a glaucoma is a condition a person is having glaucoma. There are various factors I told you to consider. So even in a glaucomatous patient, if the cup disc ratio is same, so people generally still difficult to diagnose, call it as a glaucoma case. So it is generally unilateral in glaucoma cases, and in physiology coupling it is generally bilateral.
Okay, thank you, sir.
Okay.
Good
Sir,
morning, sir.
someone has, excuse
When
me,
you
sir.
Yeah,
Someone
tell
has,
me.
sir, someone has asked a question from inbox that how to differentiate between disc pallor and optic disc cupping.
Okay.
Someone in
See,
the
optic disc cupping. I'll again share my slide. 1 minute. Can you see my screen? Right, right. Okay. Now this is the cupping is there. Okay. Cupping is here in the center here. It can be slightly away also. It need not always follow that it should be in the center. But this is the neuroretinal rim which I was talking about. So if there is a here you can see a uniform color is there. So if it is in if there is a pallor, it will be something like 1 minute. As I showed you in one of the cases, 1 minute. Yeah, see you can see this there is a small, of course here it is a hemorrhage is there, but here there will be instead of it being fully pink
Sir,
color, a patch
sir,
will
your
be
PPT is not showing, sir.
dull in color. Huh?
Your PPT is not showing. Just screen is sharing. With.
No,
Your presentation is not
And the
sharing, sir.
screen is visible.
1 minute is visible, no, it says 1 minute. I'll try again. Can you see it now? Oh, something has happened. Is it visible or not?
No, sir. It's not visible. Whole screen is
Okay.
visible, but PPT is not.
Now it is visible.
Yes, sir. Now visible.
And yes, it is.
Now is it visible, right?
Yeah, sir.
Yeah. So now I'll tell you. I'll come back again. Look at this picture here. So this is the cup in the center which is marked. This is the optic disc. This is the neuroretinal rim. If you see here, this is in uniform color. So if there is a slight dullness over here, temporal pallor, there it will be pallor means it is dull in color. So it will stand out. It will look like something, say something like this. It will look like. Okay, it's opposite of this. Actually, it will be the whole. This will be pink, and a patch of it will be slightly dull in color like this. Just check the uniformity of the color here, and if you see a dullness here, that means it is a pallor is there. That is called pallor.
Okay, sir. Thank you.
The significance of that one would be it will be helpful in neuro-optometry cases that will be helpful. Okay.
Good morning, sir. As you said, epiretinal membrane case, what was the vision for the patient, sir?
Vision was very bad. 612 it was. 612. And another eye, both eyes, he had it in both eyes. 612 and 624 it was. And since cataract was developing, so the ophthalmologist was also was said that let me will do the surgery both together. When the cataract operation is being done, simultaneously they'll remove it.
Okay, sir. So which up to what was the vision we can intervention that the surgery, sir? Membrane peeling.
So that that I think the surgeon will decide. The surgeon has to decide how severe it would be, and I mean, that is not in my domain. So I will not say, but generally, in this particular case, I remember that I told me that the ophthalmologist said that surgeon said that since the cataract is also developing, so let us wait for some time, and we'll whenever the surgery is required, we'll do it for both eyes for both of it together, the cataract as well as removing the epiretinal membrane. Because it is, if you see, there are so many videos in YouTube, you can see them how it is being removed. It is very, very delicate, but it is being done easily. So
Okay,
I think the ophthalmologist wouldn't want the patient to subject to two surgeries to separately. So in one shot, they can do it.
okay, sir.
Sir, someone has asked question in the inbox again. Sir, if I want to differentiate between CME and DME only by Opt, how can I will?
Pardon again.
Sir, if I want to differentiate between CME and DME only by Opt, how can I will?
Yeah, and CME and cystoid macular edema and
DME
pardon?
and DME only by OCT.
Okay. Cystoid macular edema, you can see those like a, you can see big holes over there, cystoid macular edema. If you see, I wish I could show you any picture of that. A lot of pictures are available. I have not seen in my practice much, only I've seen in books, I have seen that picture. But generally, cystoid macular edema, you will see big holes over there. The retina shape getting changed, and you can see those things. Whereas diabetic macular edema, both of them will be, I think, is a tricky question. Uh, Probably we have to relate with the systemic findings. Then only I think so.
Okay, sir. And there is another question: is incidence of neuroretinitis is and early symptoms of neuroretinitis.
This patient started vision was affected for her. Um, so the first thing I think they complained is blurring of vision.
Okay, sir. If somebody have any question, please go ahead and ask.
Sir, while you are taking hypertensive retinopathy, you said about um, 2 is to 3 arterial and vein something ratio. I will
Yeah,
explain it.
no, that is, yeah, yeah. And the normal ratio between arteries and veins is 2 is to 3 thickness. So in hypertensive retinopathy, the arteries will get thinned out drastically. Hello?
Okay, sir. Thank you. Thank you.
Right.
Hello, good morning, sir.
Yeah.
Sir, in Stargardt disease, you saw the picture. It's pretty close to wet ARMD. So how can I differentiate between two?
Pardon?
Hello,
Hello? 1 minute. Tell me.
sir. You have shown the Stargardt disease picture that
Yeah.
is pretty close to wet AMD. The picture. So how
Yeah,
can we
see, basic.
differentiate between two?
So AMD is with old people, age. And Stargardt disease generally happens starts in the age of around from childhood. It starts at slowly, and by when they are teenage, it is very prominent. That boy, which I picture I showed, is that of a he is hardly 12 years old, and the AMD's picture I showed is around 75 years old. So age.
Okay, sir. Thank you. Got it.
Okay.
And with this, we would like to end our session. On behalf of OPTOBHARAT, I sincerely thank Mr. Sanjay Mehta sir for sharing his expertise and valuable insights today. A big thank you
Thank
all
you.
for
Thank you very
participating
much.
and joining
Thank you
us.
very much.
At
Someone
OPTOBHARAT,
was asking some question. I saw someone. Uh, some Mr. Adnan Khan has asked. You want me to answer it?
yes, sir, please go ahead.
Yeah. He says that actually what happened, which resulted in pallor the disc, what is the pathogenesis? As we know, the cupping when actually happens, but what is the reason of palloring? What is happening in the process? Say, I showed you the picture of uh, the um, lamina cribrosa pores, right? So that part of the optic nerve is getting damaged, has damage. That is the reason why the color has changed, and that is an indicator that there is a loss of axon of optic nerve in that of the optic nerve in that area. And it is very very important. Whenever I see any lamina cribrosa pores, I jump from my seat because there's an indication that something is definitely wrong behind in the vasculature behind the eye, which we are not able to see. It's the optic nerve is such a small, tiny structure. Nobody has been able to touch it also. So sensitive it is. And when it shows something abnormality, then you have to be careful of, because those lamina fibrosa pores are, see what happens. In fact, the glaucoma mechanism is based on the fact that there is a disturbance in the whole body vasculature. Please go and read your books again, and you will. There are about there will be a definitely in your books will be written that the systemic the whole blood pressure controls the IOP also. So if something is wrong in the vasculature, so in the mechanism, the blood flow, everything, then it is going to happen. One more important thing is that if of all these years of my practice, I will tell one simple thing that you might be diabetic and still I have seen many of my patients who are diabetic for the last 40 years, 50 years, 40 years also. Absolutely, their retina is fine. But I have seen people whose blood pressure goes for a toss, and then the whole problem starts. More than anything, I would say regulating the blood pressure is very, very important than any other thing, because that controls the whole system in our body. Somebody has asked Rupa Shri Kumar. So let me, I was talking with your team. Let's see. This is just a probably starting. I have a plan to talk to you, because the eye as it is a big topic, and each subject, even glaucoma, is a big topic. So let's see whether we can do something on glaucoma, hypertension, then on dispensing, setting up a clinical practice. These are all very, I mean, crucial in today's circumstances. So hopefully we'll see later, definitely. If OPTOBHARAT calls me, I'm there always. Someone says you can join OPTOBHARAT community. Yeah, I'm a student also still. If anybody questions wants to ask, otherwise we'll.
I think we are done, sir.
They are done? Okay, fine.
I think.
Thank
Okay,
you very
sir.
much.
This concludes today's session. Wishing you all.
Hello, someone is asking. Yeah, I think we are done, right?
Mm. Yes, sir. This concludes today's session.
Pardon?
I mean, this concludes today's session, sir. I
Yeah,
think we are
yeah, yeah. Fine, ma'am. See you.
okay.
Bye,
And thank you
everyone.
so much, sir, for coming here for bring
Yeah, yeah.
for
Just
taking some
so
time
one
from
thing,
your busy schedule.
one small takeaway to everyone is 6, 6, and 6 is not enough. Just look beyond that. That is what I will say. If a patient has 6, 6, and 6, I will never consider it to be normal, because all of these my cases, 75% to 80% of the cases what you have seen today, even all of them have come. They had 6, 6, and 6 vision only. So, but still they had problems, issues. Okay. Thank you very much.
Okay. Thank you so much, sir.
Right,
Thank you.
right.